welcome everybody to the launch event of the Global Surgery Policy Unit of the London School of Economics and the Royal College of Surgeons of England. I'd like to thank all of you for coming out on a cold Friday night to join us and the people who've joined us online. I'd also like to say a few other thank yous. I think firstly, it's important that we thank the people who had the vision and the concept to set up this unit in the first place. And particularly like to thank Baroness Minouche Shafiq, who is the president of the LSE, Professor Neil Mortensen, the president of the Royal College of Surgeons of England, and his predecessor, Professor Derek Alderson, who started the gestation, as it were, of this unit. Both organizations have had almost, as it were, parallel interests and long and distinguished history in the field of global health or global surgery. Those of you that are here from the Royal College of Surgeons will know the extent of the diaspora of college alumni who practice in low middle income countries. Those of you that are from the LSE side of things will know the investment and work that the LSE has done and is doing in the field of global health. And my understanding is that after the Lancet Commission in 2015, which I'm sure we'll hear more about from various speakers tonight, the recognition of the huge unmet need for safe, affordable, timely surgery worldwide. Despite the sort of many worthy efforts of professionals, academic institutions, charitable organizations, and so on, it is not clear to me and to many other people, I'm sure, as to whether we have actually improved that headline figure of 5 billion people lacking access to safe surgery. And if you think about some of the wars and other natural disasters that have happened over the last 8 years, that need for safe surgery worldwide is at least as big as it was when the Commission reported. And hopefully tonight you'll hear something about some of the challenges that need to be addressed. Because of the very complementary expertise of the college with its sort of very much clinical history, and the LSE where the financial levers around policy, politics is much more their expertise, it really was very visionary of people I've mentioned and other members who were involved at the time to bring together those two organizations to try to look at the policy aspect rather than replicating the many worthwhile endeavors that are being done by organizations represented in this room and others worldwide. My co-director, Rocco, will say more about that in a moment. In terms of welcoming you here to the launch tonight, I have one sort of announcement I've been asked to make, which is that the meeting is being recorded. So if anyone has an objection to that, I think you have to leave now, but please don't all rush for the door at once. Thank you for that. So tonight we are delighted that we have our speakers, or most of them here. As of yesterday morning, I think we only actually had one of our speakers in the country, and I was dreading my phone ringing as different people either rang or text to say, I'm at an airport, my flight has been cancelled, etc., etc. But we actually do have most of our speakers here tonight, and Professor Sherry Wren, who you can see on screen, will join us by Zoom. We also have a large number of people who've joined us by Zoom as well. We hope that they'll be able to interact with us during the course of the evening by typing questions or comments into the chat line, and that will all be monitored and they can take part as much as those of you in the room. So welcome everybody. I'm going to hand over to Rocco Freeball, who's my co-director, to say a few words about the work the unit is starting to do, and then to introduce the keynote speaker. Thank you, Rocco.
Yeah, thank you, Rachel. And again, on behalf of the London School of Economics, really a warm welcome to everybody who has come out today on a Friday evening. I've been told several times by various people, are you mad to host an event on a Friday night? People have better things to do. But I think, we can prove that this is definitely not the case. And this launch event is attracting quite a large number of people, virtually, and of course in person. So there is a great need for this global surgery policy unit. The momentum that has come out of the 2015 Lancet Commission on Global Surgery has led to the rise of many global surgery units across the world. And many of them are producing important research that should not be ignored and should be translated into policy and practice. And yet, unfortunately, progress in the field of global surgery has actually been rather slow. Take, for instance, this global drive for national surgical plans, which have been developed across various countries, but many of them have failed to take off. Or think about the lack of funding for surgical systems, which is still not really on the agenda of many decision makers, many governments, leading to the lack of access to surgical services for millions of people across the world. This global surgery policy unit strives to shape the future of global surgery by acting as a knowledge broker, connecting those who are generating the evidence on the one hand with those who are in a position to change surgical systems at a policy level. And we will do this by we will do this through 3 core pillars. The first one is research. And again, we're not trying to replicate any of the research that is being conducted by global surgery units, but really about conducting research on topics that are crucial for decision-making and system strengthening. We have one pillar that focuses on education, and that's about providing people on the ground with the tools and skill set to actually inform policy decision-making. And then finally, it's about advisory, working closely with governments, ministries of health, ministries of finance, NGOs, advocacy groups, to see through the needed change in policy and practice. So to celebrate this new partnership, we have brought some of the leading voices of global surgery in the field to this event. And it's my great pleasure to introduce the keynote speaker of today's event. I'm just switching the slide deck. Professor Abebe Bekele is the Dean of the School of Medicine at the University of Global Health Equity. He's a professor of surgery and has served as CEO of the Black Lion Teaching Hospital and Dean of the School of Medicine of Addis Ababa University in Ethiopia. He is also a full professor. He's a full professor at the Addis Ababa University and the University of Rwanda. Professor Abebe is a member of the Governing Council and chair of the Examinations and Credentials Committee at the College of Surgeons of East and Central and Southern Africa, and editor-in-chief of the East and Central African Journal of Surgery. He has published widely and has received various national and international awards. Professor Abebe is a giant in the field of global surgery. He is actively engaged in global safe surgery and anesthesia initiatives and has served as a senior advisor to the Federal Ministry of Health, Ethiopia, in the Saving Lives Through Safe Surgical Initiative. It's a great pleasure to have you here. Until last night, huge uncertainty whether you will actually make it, but please all join me in welcoming Professor Abebe.
Good evening, everyone. Let me first start by extending my appreciation, Rocco and Rachel, for the kind invitation to invite me here to be your keynote speaker today. And my words of congratulations, representing the Center for Equity in Global Surgery in my university. When I was invited, when I received the email from a School of Economics about a center in unit in global surgery, I was surprised. What is the relationship between economics, politics, and global surgery? Eventually, things became clearer and clearer. And I must say, this is a very unique unit that will have a huge impact in how global surgery is conducted, mainly where I came from in Africa. So congratulations on what you have done. My talk today, 25, 30 minutes, will be about my experience around partnerships in global surgery. And thank you, Rocco, for the very kind introduction. I have nothing to declare for the speech. And my talk is mainly based on a few of the publications me and my colleagues have done in regards to partnerships. The way I understand global surgery for me is everything that has to do with access to care and outcomes to anesthesia and surgery. Deals with research, the practice, teaching and learning, development of policy, advocacy, everything in surgical care. That is how, not just me, but people in Africa, the professionals want to describe global surgery, not just the research piece of it. Before I go deep into the substance of the talk, I thought it might be a good idea to recap on what global surgery, the way I see it, what happened the past many, many years. The evolution of global surgery kind of is a reflection of what global health went through, from tropical medicine in the 1950s, 60s, to humanitarian medicine, humanitarian health. Then the dialogue changed to international health, then became global health. And I think global surgery is a spin-off what we called global health. At the moment, the dialogue is, the debate is between, are we dealing with global health equity, or a terminology that came recently, decolonizing global health? I'm not a big fan of the word decolonization, because decolonization comes with some strong negative connotations. It creates enemy when there is none. It talks about power dynamics, where there is an oppressor or the oppressed. It talks about removal of an oppressor, an enemy, while there is a rosy term to the dialogue, equity, which is associated with things that are positive. Talks about universal access to care, access to education, inclusion, diversity, quality. So the way I understand global surgery is in terms of equity in global surgery in anesthesia, not the decolonization aspect of it. Before the 2000s, the dialogue and the practice of global surgery was mainly humanitarian, mainly service and care associated. I suspect some of you have good experience working in Africa in the 90s, before the 2000s. A lot of academic work. Many of the medical schools, residency programs in Africa are set up by partnership with some developed institutions in the world. Research and project-based partnerships were significantly limited, because I don't think the environment was conducive for that kind of engagement. And many of these partnerships were mainly individual-based and a few institution-based. And surprisingly, there were some partnerships that promoted referral of patients outside of Africa, diagnosed patients in Africa, but care being given elsewhere. And to create some historical parallel to the prevailing understanding of surgery. By then, surgery was said to be very expensive. It's not cost effective. It's not economically realistic. There was this understanding everywhere that it's not a basic health need. There were very few surgical patients in the world. And it needed highly trained, quite specialized resources to provide the service. When now we know 1/3 of the global burden of disease is surgical. So in these 20 years, things significantly have changed. 2008, surprisingly, 2 internists published a paper about surgery and surgical outcome, a view beyond from beyond the theater. Paul Farmer and Jim Kim. From what I tried to study, this is the very first paper that touched a bit about the public health aspect of what anesthesia in surgery looks like. And Paul used to be the chancellor of my university. Unfortunately, he passed away last year in February. And Jim is now the chancellor at UGHE. Both founded an NGO called Partners in Health in Boston in the end of the 1980s. And the term surgery is the neglected stepchild of public health was coined by Paul, I think about 15 years ago. What I just wanted to mention here is that the very first people who tried to link surgical anesthesia practice to public health were not surgeons, were internists. And then came this publication, 2007/8, about HIV prevention and circumcision from Africa. I think this was when people started to understand surgery has a direct impact on infectious diseases. Strengthening surgical services has impact in strengthening other healthcare services. In 2015, as almost most of us know, these three important events took place. The publication of the 3rd volume of Essential Surgery, the Lancet Commission publication, and the WHO resolution that were real landmark events. And this, what happened in 2015, is the reason why. There are many global surgery units, centers, institutes across the world. We set up our Center for Equity in Global Surgery in 2022, last year. Many of these centers, including ours, mainly focused on academics, teaching and learning, a lot of global surgery research, some work around National Surgical Anesthesia Plan, and resident exchange from the global north to south, things like that. That is why this unit that focuses on policy, I think has something different to contribute to the dialogue in global surgery. We tried to do a small publication around what global health equity in surgery means a couple of years ago. And our understanding of equity was that I underlined a few words, as you can see. Global health, global surgery is mainly about partnerships, processes, and outcomes, products. So we cannot talk about a successful global health engagement without talking about equitable partnerships. The partnership is the basis behind the success of global health and hence global surgery. Partnerships, simply speaking, it just simply means working together. Working together, but how? Partnerships should, or at least should be based on a reciprocal and bilateral benefit, a win-win for both, for all parties involved in the dialogue. It certainly should not create the sense that there is a debtor and a creditor. It's not a gift. It should not be a gift. And by no means it should be equated with charity. And in short, academic partnerships can help improve access to and quality of care, decrease disparities in the world, and strengthen health systems. But if partnerships are managed badly, again, using the word I would prefer not to use, it may become the bold new face of neocolonialism. Partnerships can be created between several institutions. It can be government-led, government to government, multilateral, bilateral. It can be between academic institutions and non-academic institutions, research institutions. It can be between the private sector and the industry. It can be just for research. Partnerships can exist between two organizations who share the same vision. However, today's partnerships, to be fruitful, to be meaningful, should follow a certain pathway. Number one, there should be careful planning. Just because opportunities present parties should not sit together and decide to work. There should be clear planning based on the local needs. What are the needs here in London? What are the needs back in Rwanda? Those need to be very clearly put on the table, discussed, and agreed upon. And there should be clarity on what is expected to be done. Clarity in terms of goals, roles, responsibilities. It should be based on equity, trust, transparency, ownership, and respect. There should be demonstrable benefit for both. It should not be just give from one side or take from the other side. There should be a clear benefit demonstrable for both sides. And there should be a learning curve at the end, what we call sustainability or capacity building. Partnerships that don't result in capacity building are wasted opportunities. And there are valuable considerations when we think about partnerships. Consensus-based decision-making. Things should not be decided from one side and kind of exported somewhere. There should be accountability, shared leadership. Capacity building is critical, is really critical. And the continuous learning that ends up with in sustainability, I think are really, really important. Now, partnerships, my experience has been, these are very successful. These are good news for everybody. Sometimes they are really bad. Sometimes they are really bad. In other words, there is the good side of partnership. For example, I want to just mention a few. Partnerships that are based on specific skills transfer. Particularly capacity-based initiative-led research projects. Partnerships where teaching and mentorship is built into and research is involved are really, really, really successful. The experience of the College of Surgeons of East Central and Southern Africa is, I think, a very good example of what successful partnership looks like. If you could, the college works with several partners, several colleges in the world, in the US, in the UK, Scotland, Ireland, and in Africa. If you look at this picture taken in 2018, these are the COSEX, these were the COSEXA exams, the general surgery exams. COSEXA heavily depends on its partners to do the exams. Last year, from 212 examiners, 53% were from the global partners. This gives flavor to the exam, reliability and validity to the exam, and helps us a lot in training and examining a lot of our candidates. Many of you, I see familiar faces here who are really long-standing partners of the college. Second successful partnership is the university I am the Dean of the School of Medicine of. I want to mention the partnership between a private institution and the government. The support given to us by the government of Rwanda and its sector ministries has been enormous. And academic institutions that helped Partners in Health, the parent institution of UGHE, set it up in Rwanda and run it has been enormous. And these are the academic partners we work with in developing curricula, in teaching our students, designing mentorship programs, designing support to students. And that is recognized by several bodies. We recently received an award entitled The Power of Partnerships. If partnerships are managed well, they are really, really, really helpful. However, not all partnerships are healthy. In other words, I may want to define what we call disorders of partnerships. These are, in my opinion, diseases that we need to think about before we think about partnerships. The first one, the diseases of partnerships, the genetics mainly arise from certain assumptions about Africa. I've met several people who ask me where I am, and I say I'm from Ethiopia. Oh, it's in Africa, yes. Do you know John from Nigeria? It just doesn't work like that. It doesn't work like that. Africa is not homogeneous. We share several successes, several problems, but we are not identical. So a program that worked in Nigeria probably will not work, cannot be copy-pasted to Rwanda. There are some that say Africa lacks the capacity to build stable states and durable law and order. Hence, they lack the systems. Hence, they accept prescriptions. It doesn't work. It doesn't work. Problems in Africa need to be thought about and planned upon with the stakeholders. Prescription partnerships do not work. And unless the partnerships takes into account the considerations of the people and the culture there, they will not be successful. So the first disease of partnerships I see is what I want to call ectopic partnerships. These are partnerships, research, or projects mainly based on priorities of funders. Probably does not address what is on the ground. It is not relevant to problems in the continent or in that specific country. And I sometimes ask myself, even to think about research in Africa, you need a room, you need an office space. I can't understand when some funders say bricks and mortars are not allowed in through this grant, when it's clear need in that specific country. So is the funding for the partner in the south or in the north? I sometimes ask myself. Now, most of the time, the PI is from the global north. I don't think it's because there is no one capable of being a PI in the south. And local partners think they are employees, not just partners. And sometimes copy-paste partnerships. What worked somewhere is assumed to work elsewhere. What worked in the Sudan probably will work in Uganda. That's completely wrong. What's good for the goose may not be good for the gander. The second is what I wanted to call the ghost partner syndrome. It can be the vanishing partnership syndrome. This is a situation where the products of the partnership are no more accessible to the partner in the south. The data is kept somewhere else. The output is kept somewhere else. The paper is published in a huge, highly guarded journal that you pay maybe $1,000 to get the paper from. The local authors probably see the title in the abstract. Too often, the local partners are not even recognized in publications. Maybe at the end, acknowledgement, there might be some names. And right after the funding ends, the project disappears. And this is true usually for registries. Trauma registries, cancer registries, you name them. As long as the funding is there, they exist. As soon as the funding is gone, the partnership is gone. The third is inflammation. Pilotitis, conceptionitis, baselinitis. This has to stop. This has to stop. Global surgery has existed officially for 8 years now, and in practice for more than 30 years without getting the name global surgery. We have tried it several times. And this disease is self-limiting. As soon as the funding stops, the disease stops. But it leaves a scar. It introduces a new system or a new approach to something. And then the need is there. Unfortunately, it's recurrent. Somebody else comes with this, another funding to do the same thing. The same concept note is repeated, or the same pilot project comes back again. The fourth is partnership shunt. Why are headquarters of partnerships in the global north when everything that's being done is in the global south? What is wrong with housing it in the global south? This perpetuates colonialism of the mind. People are expecting orders from somewhere. They feel they are employees. It continues to inequity, continuous inequity. And the majority of the resources is pushed back to the global north. Office space, rentals, some salaries, some resources. And it completely misses the capacity building piece. Capacity building comes in different forms. It comes in the form of vehicles. It comes in the forms of buildings. It comes in the forms of computers. The fifth is partnerships disequilibrium, or what I can call ataxia. These are unbalanced expectations and realities. A professor in Uganda should be a professor in the UK. There is absolutely no justification to call him a lecturer here. Then where is the equity? Someone who has spent 25 years in Africa, operating, doing research, why aren't they considered as equivalent, let alone equal, to partners in the global north? It just doesn't make sense. The full-time equivalent calculations of research partners or project partners, publications, data rights. Unfortunately, the end product is usually guarded where the funding is. And often it gives the impression that the other partner is not so relevant. The dependency syndrome is the sixth. So much effort for so little. Sometimes, unless some famous names are included in research proposals, that proposal will not pass. It seems there are some columnists, known columnists, the funders recognize. Then how do the other side, how do they stand a chance? And the financial requirements, the ethical requirements, the language issue. English is probably a second or third language for most Africans. How can you compete with native English speaker when it comes to proposal development? The way the word count, the way the font, the whatever, how is that related to global surgery? All this contribute to bad partnerships. Dependency. You have to look for a known grant writer, a known researcher in the global north, and apply for grants. It goes on and on and on again. The seventh is partnerships around equipment donations. I want to show you my own experience. This is my thoracic surgery theater in Addis. Used to be my theater, 2015. A colleague of mine is operating. Just a quick look at it, you think it's a theater in the UK. It's a beautiful theater. I went there a few weeks ago. I operated there. Still very good. But look across the window. I'm not lying. Across the window. These are donated equipments from the US. To the extent somebody tweeted about it. And it's quite unfortunate. I was the CEO of the hospital when this picture was taken. So sometimes equipment donation results in such a beautiful setup. all this equipment is donated. Sometimes it's like an equipment graveyard. So unless partnerships are managed carefully, this might be the result. The 8th is about surgical missions. From my review, quite some time ago, a total expenditure on short-term medical missions, include surgical missions, about $250 million are spent. This is about 15 years ago. I'm sure the number has changed significantly. And about 2 years ago, I also found this publication. If you could just pay attention to the conclusion, short-term missions, the conclusion is they may be more expensive than previously thought. The cost to treat one patient in South America as a result of the missions is probably similar to a medical office visit in the US. The investment that missions put into when they offer services in the global South are expensive, are really, really, really expensive. And most importantly, surgical missions are sometimes life-saving. They really make a difference. Pediatric and adult cardiac missions. This service is not yet strong in Africa. So such missions really, really save lives. Complex plastic, neurosurgical, orthopedic missions, they save lives. Sometimes missions introduce innovative healthcare. Kidney transplant. Ethiopia started its kidney transplant in 2015, I want to say, through missions. And mass casualties are there, national disasters are there. We can't run away from missions. However, how do we explain missions for the bread and butter surgical cases? How do you explain hernia repair missions? How do we explain varicose vein repair missions? Unless we are, pragmatic about it, honest about it, it can't change. During missions, this huge photo op coverage in the social media, in the newspaper, in the press. There were, in fact, some missions that even went to the prime minister in Ethiopia. I was the dean of the School of Medicine, the CEO of the whole. I've never met the prime minister, and they did. And I was invited to accompany them. And are we sure all those involved are experts? Because several times we have found they're not. And how do we explain missions to a certain country for the past 20 years without capacity building, with no exit strategy? Surgical missions sometimes interfere with regular service, regular service. A couple of years ago, all of us were kicked out of the Black Lion Hospital. Black Lion has 10 operating theaters for cleft procedures. All of us from 10 theaters for 2 weeks. The lucky 200-something patients with clefts got operated. How about the regular schedule? How about the unfortunate breast cancers, the colon cancers? Missions where there is very little local involvement. Who's going to prepare the patients? Who's going to screen them? And most importantly, who's going to follow them? I was stuck with several post-open heart procedures. I'm a cardiac surgeon. When the mission goes back, we have to deal with the complications. Sometimes missions introduce non-sustainable options of treatment. 2011, mesh repair was introduced to Ethiopia. Mission came, operated for 2 weeks, and then they went back. There were no meshes left. So how can that be sustainable? How can that be sustained? The people want it. They are asking for it. And let us rather wait for the mission syndrome is created. Oh, we don't want you. The local surgeons, we don't want you. We're going to wait for the mission. That destroys a system. That destroys trust. Having said this, some things never change, where we are all human, and they never change. We're always going to have conflicts. We're always going to have refugees. Pandemics, we've seen two years ago. Natural and not so natural disasters are regular. There is an intense or a severe demographic shift of diseases. Cancers in Africa, it's unbelievable. The society that's now well educated, have access to information, and they insist on better care. There is need for better education and better research. And it's in both hemispheres, the southern and the northern. And we depend a lot on partnerships. We can't do this alone. We can't do this alone. We need to be careful about the sustainability trap. One good reason why funders refuse to fund projects is, how is it sustainable? My answer is, sustain what? At the beginning, there is nothing. Baseline, there is nothing. The gold standard is up there. Because of the partnership, the project, some things might change. A new baseline might be reached. But the time to talk about sustainability is not now. If we just look at the 20 per 100,000 mathematical modeling, the number we're using in global surgery, Ethiopia needs 20,000 surgeons, OBGYNs, and anesthesiologists today. There are less than 600 surgeons in the country. Sustain what? There is nothing. So how do we get there? I think together is the most important word, and one step at a time. One step at a time. And with rare exceptions, all the most important achievements in the world, in this planet, will come from working together. In other words, with partnership, through partnerships. Thank you very much.
Hope you can hear me. Thank you so much for this fantastic talk. And I think, thinking about, the partnership element is so crucial. I mean, considering that we are a brand new unit, trying to, find our way, our place in this landscape, and trying to come up with solutions, that are sustainable, that are impactful, and are, building on this equity aspect that you discussed. I think it resonates very well with what we're hoping to achieve. And if you don't mind, we do have an opportunity to ask some questions from the floor and online. So if anyone would like to ask a question for Professor Abeba, please raise your hand and we will circulate one of the microphones. One here in the front, please.
Thank you so much. We enjoyed the talk, very inspirational as always. Back in 2015, I was at the RSM when they launched the Lancet Commission, Richard Horton and everybody else, and laid out the plans of what was required. But since then, that's now 7 years, we've had to deliver any changes from what I can see. Why is that? And what should we do as a community to actually invoke the change required for surgery to become more equitable?
Thank you very much for the question. I don't think I have the answer to that. I can contribute a little. I think one of the most important is we haven't yet started working together. There are close, I don't want to mention numbers, but several global surgery centers in the world. How many of them talk to one another? How many of them have a global forum where they discuss? If you bring it to them, meso level in the middle, how many projects are in one country related to global surgery? Do these projects talk to one another in the country? You can bring it down to the institution level, the university level. There are several projects. Do they talk to one another? So I think we have failed in that. The word global in global surgery should mean something. It means working together. So I think that one reason we are not yet there is because of that. I mean, don't get me wrong. Some extraordinary things have been done. The data generated because of the movement is enormous. Some countries have woken up. They have started planning. They have started mobilizing their workforce. They've started fundraising. But it's not enough. So I think key would be, how do we start to work together? Yeah.
How do you do? Dion Morton from Birmingham. Very engaging talk, centered around partnership. I think some of the challenges in partnerships we are starting to address together. The funders are now requiring that the lead applicants are partnered from around the world. And I think the journals are recognizing that you must have equitable partnerships in publication. We really promote corporate authorship where everyone is recognized with equity. So I think there are small moves there. I liked your last point, which was about the need for interaction between global surgery units around. Sometimes I think they're parochial surgery units; they're not really global. And I think joining them up, the South-South learning is really important. And if we can actually promote the global surgery units to join together, then we'll increase the influence and the rapidity of development. Do you have thoughts in that area?
Yes, the first point you've made, there are several steps already taken to, for a lack of a better word, correct the partnerships. It's not enough, obviously. There is always room for improvement, and there is a lot to be done. A lot to be done. In 2015, the word NSOPs was introduced, and the resolution states that all countries should have their plan soon. How many have done so? It's been 8 years since the resolution was done. I don't think it's because the countries do not want to do planning. I think they want to. But how is a surgical plan done? Do we know? There is funding needed to actually plan. How many ministries in the world have separate divisions for surgery anesthesia care? Ministries have divisions for maternal health, for non-communicable disease, for vaccination, immunization, but not for surgery. These are things that need to change. Helping governments achieve this. One of the reasons I'm really excited about this unit is because of this. The unit is strategically placed to generate the data and advise governments and help them plan, implement plan. And imagine if all the global surgery colleges sit together. I think there are about 11 of us, including COSEXA. If there is a forum where we sit and discuss about exams, about intake, about placement, about research, about mentorship. I am saying this because I am in the southern end, and I know how COSEXA has benefited from the partnerships. the Royal College here, Edinburgh, Ireland, individuals. I mean, there are several of you I see. These partnerships change the world. It has changed COSEXA a lot. Imagine it's 100 of us. Imagine it's everybody sharing of resources, no competition. The main objective is getting things done, not competing with one another. So I think the very first thing that needs to happen is to sit together in a room and talk, discuss. That's how it should start.
Thank you. I wanted to give the audience online an opportunity to ask one question as well. Dashita, if I can just ask you to select the question, please.
Yes, thank you, Professor Ebebe, for that talk. It was really interesting. I have a few questions online. So the first question is, what is the place of South-South partnerships in improving equity and reducing neocolonial tendencies?
Thank you. I wouldn't respond to the neocolonialism question, but South-South partnerships are critical. Good example is our partnership with the West African College of Surgeons at COSEXA and the CMS, South African College. We share resources, we share examiners, we talk, we discuss, and they're really critically important. To make it even better, North-South partnerships work. Some years ago, some institutions from the global north used to work with institutions in Africa. Now, these institutions have reached a stage where they are now assisting other units. So the partnership has gone beyond just one country. It has gone to others. So North-South, South-South partnerships really work. They really work.
Thank you so much. I have another question, which is asking, would love to hear your perspective why global surgery seems to struggle to be truly included as a part of wider global health agenda.
Let's just say it's only 7 years old. I think we can measure the success rather than its weaknesses. We have gone this far in 7 years, which is good, very good. There are more things to be done. Number one, let's work together. Let's have a common vision. Let's not make it about ourselves. Let's make it about the objective, that's access to care, equity, the vulnerable. And if we change this perspective, I think there's nothing that cannot be done. The definition of global surgery, I think, needs to be taken into account because I've seen it varies from center to center. For some, global surgery is an opportunity for trainees and students to come to the global south and get the African experience, which is good. For some, it's research. For some, it's community engagement. But for some of us, it's everything. At the end of the day, access to care. So if we agree on a common definition, if we agree on a common vision, I think the coming few years we'll do a lot.
Okay, so in the interest of time, we probably have to finish here with the keynote speech and the Q&A. But I'm hoping that you probably don't mind taking a few questions at the drinks reception afterwards. So please join me in thanking again Professor Ebebe for the fantastic job. Thank you, and I'm just handing over to my co-director, Rachel.
Thank you very much. Well, that's got us started in a marvelous way, and I hope now that you will join me in welcoming our panel to give their perspectives on different aspects of global surgery. We have 4 speakers for you, 3 here in the room, and thanks to the vagaries of the international airline industry who seem to be conspiring against us yesterday, Professor Sherry Wren is online. what we've asked our panelists to do is to each come and give a short talk on a particular topic that maybe presents a challenge or a controversy or something that they feel is important in global surgery. Each of them will speak on that topic, and then will join us for panel questions and answers all together at the end, if that's okay. So our first speaker, who's going to speak on the subject of delivering safe surgery, is also from Africa, and we didn't make the mistake of asking, did she know our first speaker, but actually they do know each other, even though Africa is a very big place, I've been informed. I'm delighted to welcome Dr. Tintena Ngusi. Now, she is a general and pediatric surgeon in Addis Ababa. But many of you may also know her because she is the Global Clinical Director for Lifebox. You've already seen, I think, the Lifebox logo on one of the slides previously, and we're delighted that their CEO is here with us tonight as well. So I'd be most grateful, Dr. Ngusi, if you'd come and speak to us on delivering safe surgery. Thank you.
Good evening, everyone, and thank you, the Global Surgery Policy Unit, for this invitation and making us one of the speakers on global surgery. So when we talk about global surgery, yes, we are trying to address how people will get surgery wherever they are and whenever they've got the disease. But as part of surgical service intervention, access should come hand in hand with safety. So WHO started to talk about surgery of almost for 15 years as a policy, and it also advocates about safety by starting working on the WHO surgical safety checklist, where most of the surgeons and the anesthesia team know. So when we talk about access, if you are delivering surgery in the wrong way, just to make sure that the people get surgery, it's not right, because you are causing more expenses, more psychological traumas, more disasters. So always, when you plan to implement surgery, when you plan to advocate about global surgery, make sure that safety is hand in hand with the access thing. So when surgery comes in mind and when the access is an agenda, the reachability, which means the timeliness of the surgery for whenever the demand arises, and the affordability, because most of the patients, especially in resource-limited areas, will pay for their surgical intervention. So they will avoid having the surgery unless it is killing them or causing them severe disability. And whenever the access, the infrastructure is there, unless the important human capacity is not there, then it doesn't matter, because the building is there and the right person operating will not be available, so it will not save the patient. And automatically it will result in increased morbidity and mortality to the society. So always when we plan about surgical intervention, we don't have to plan anything to increase the number without safety measures. So why safe surgery? You know, as a pediatric surgeon working in a resource-limited area, I know the challenge in the area of safety, because kids are fragile and you do have small threshold of tolerating anything. So if you've got a patient and you're not taking the right measures, you see the picture of a patient having colostomy. It's just for a Hirschsprung's disease. The colostomy took only 45 minutes. Once the colostomy is done, the patient will be discharged within 2 to 3 days. But unfortunately, because of the surgical site infection, the wound dehiscence, the patient stayed for more than 2 weeks. Imagine the psychological trauma to the parents, the pain and the dressing were causing the patient's discomfort and morbidity, and the cost to the institution where resources limited, where you can use that bed to operate more than 5 patients within that 2 weeks. Now you are keeping only 1 patient on that bed and you are wasting the resource. Then the waiting list, the caseload, everything will pile up. And when you are talking about unsafe surgical intervention resulting in substantial harm to the community, the society, the government, the institution, then what is the place of surgery? So as much as possible, preventable things should be prevented. Otherwise, better not to intervene and bring on damage than saving the patient's life or the overall surgical ecosystem. So what are the gaps of bringing this unsafe surgical intervention in this area? So the 4 S's, the infrastructure or the space, the limited resources like just the equipment, the consumables and everything, which is the stuff, and the limited human capacity in number, in subspecialty, and finally the process, the system of on-time referral, the system of getting the right access, the right place. So complicated patients should being referred to the exact center without being delayed in multiple stop areas where the care is not available, and which will result in preventable and unnecessary complications to the things. So in area where resources limited, this should be planned ahead of time, because if your intervention results in significant complications, then your resource limited will be significantly compromised and results in unnecessary cost implication to the government, the institutions, the families, the community, and everything. So how can we approach safety measures? There are different ways, the one which works for Ethiopia, as Prof. Baba said, will not work for Rwanda. So it has to be context-based, and that context should be assessed by the focal person on the ground. The plan should be done by the already involved person who is doing the right intervention, especially the surgeon, the anesthesia team, the nursing in the perioperative areas. But the support can be delivered anywhere where the vision is there in the global area. So WHO has come up with an idea of including surgery as part of the policy. So still though 1/3 of the patients deserve to have surgical intervention for treatment, the attention given compared to medical diseases or other issues is not that much remarkable. But as a person, as a surgical person working in the area, we need to be the advocates of pushing the WHO, pushing the Ministry of Health, pushing the non-governmental organizations and others to give more attention to surgery, because the impact, the economical impact is significantly good when patients have got the right way of surgical intervention. So it looks like it's an expensive department. When it comes to the outcome, it is one of the least expensive departments in caring for patients. And as you see the name here, Lifebox is a foundation which has been started 11 years back. And one of the department or one of the institution or a foundation which advocates for safe surgery globally, that is the vision. And this is saving lives through safer surgery. So we do have 3 standard pillars to address the important areas in the perioperative area, which is anesthesia safety, surgical safety, but one of the most important is the teamwork. surgical teamwork is the area we need to work on. So the partnership on global surgery, the partnership in safe surgery starts from the partnership among the staffs working together. So we need to understand each other. We need to read what other colleagues are thinking about the safety of the patient, because at the end of the day, all the 3 team members will go to the operation theater, making the patient the center of attention. So why don't we read each other? Why don't we understand each other? And why don't we plan together? So that is the main important aspect of LifeBox approach. So in order to address the safety of patients, there are different ways. The most important way that the foundation follows is availing tools. The tools should not be expensive, but if it is mandatory, it has to be there. For example, if you're not addressing anesthesia safety without properly following the oxygen level of the patient, just putting the pulse oximetry as mandatory equipment on the checklist doesn't work. You need to bring it. How and where you need to look for organizations, partners, which can be availing this kind of gadgets. So you need to look for options. The same thing works for the different protocols, standards, because these things might not be there at the institutional level, but we can use experts. We can use experts in supporting in the development of these things to avail it at the institutional or the operating areas. And the other thing is capacity building. As I said earlier, capacity building depends on different areas. It might be on specialty or subspecialty, but even on the area of soft skills, capacity building, which mainly addresses the human factor and the system factor of bringing safe surgery practices, so we need to think of how to train and what to train on the aspects of safe practices. For example, the WHO surgical safety checklist implementation training, people knows about it. There is still a challenge of implementing it at the operation all over the world, not necessarily in resource limited areas, even in the developed areas, there is still a challenge of implementing WHO checklist. But you need to come up with strategies, customizing it, modifying it. So it's not a Bible or it's not a Quran, which you have to use it as it is. If you want to use any kind of checklist, if you want to use any kind of SOP, make sure that it fits to your system. So the training really works on modifying and strategies on properly implementing it. It's the same thing with the SafeOR course or the other notes course or anything. So bringing the team together, having the challenge address together, and improving the system where they are working at will be one of the strategies that can be used to improve the safety practices. But the most important thing is partnerships. There are different organizations working on global surgery, safe surgery, availing surgery, or access for surgery. If these different organizations are doing the same thing, so expending these resources without reading each other might cost you a lot. If you partner with the same vision, you will synergize your impact at the ground level. So that should be the strategy that can be easily addressed in improving the safety of patients, in improving the system, in bringing change and others. And this partnership, yes, it works with different organizations, as you said here, but the most important partner as any kind of organization is the community, the individual level that you are working. So you need to look for champions at the ground to strengthen your impact. Those champions will be used as a symbol or as an example to cascade your program, to make it sustainable and to make it impactful. So since Prof. Habebe talked about partnership, I'm not stressing more on that, but among the partners, make sure that as global surgery advocates, you need to get the low focal person, the focal champion to strengthen your work, your impact. And the last but not the least is for any program, for any training, for anything, planning sustainability at the start should be the strategy, because especially as non-governmental organizations, once you do a program, when you leave, the program will live with you. So you have to make sure that the way they are going to continue the lesson learned, the important, but it doesn't have to continue as it is. They can customize it, they can take only the lessons, but it has to be planned just as the initial phase of the implementation of any kind of program. And that will solve the disaster, comparing about the disaster and other things. So that's all, thank you. And
Thank you very much, Dr. Negussi. I think that's set us on the right track for the session now. And I'd like to move on now to Dr. Malik Zaban. He's a neurosurgeon who trained in Cardiff, actually, but has moved on to greater things. And he is now Associate Professor of Neurosurgery and advisor to the President of the Arab American University of Palestine, which is a fairly new venture that he's going to tell us about. And he's going to talk to us about surgical training experience from a conflict zone. Thank you, Malik.
Thanks, Rachel, for the introduction, and thanks for the organizers for the invitation. It's obviously my pleasure to come back to London. Just being away for 4 months was enough to kind of feel already like the spirit to come back. So yeah, what I'm going to share with you tonight is really some of my experience based on our attempts to develop postgraduate medical education in Palestine as part of my work with IMED 2000, the International Medical Education Trust, something which I enjoyed doing alongside the Professor Colin Green, our founder, who's a professor in surgical sciences. I believe he's with us online. And I did this during the 15, 20 years I stayed in the United Kingdom as a PhD student, and then later on as an academic trainee, initially in Southampton and later on in Cardiff. And also I'm going to tell you probably a little bit more about the last few months as I got appointed as an advisor to the president of the Arab American University of Palestine, with its 2 campuses in Ramallah and also in the more disadvantaged area of Jenin, which has been pretty much on the news in the last 24 hours. So, well, look, it's a conflict zone. Yesterday morning, my plan was to start a normal ward round, followed by a clinic, and then get into my taxi to fly to London. And then this raid, which is pretty much in the news, and I don't want to divert from the academic nature of the meeting, happened. And I had to cancel everything, jump in my taxi, and just barely made it to the airport to be with you tonight. So with that in mind, as you can imagine, the challenges are multiple, and you could see these challenges on the faces of people, whether the people are surgeons coming to their theaters in the morning or patients attending their clinics. And to summarize all these points, quite often people feel like helpless and hopeless. Something which is we're not used to in this country. And this is where, like, when you work in a conflict zone, be thinking about, okay, like, I mean, when you get called in the middle of the night to go and evacuate an acute subdural hematoma or an intracranial bleed in this country, all what you think about, oh my God, I'm going to get off my bed now and go and do it. But there, you're traveling and you think, oh, I may get shot on the way. And then bye-bye. It's these kind of things where quite often, like, I mean, we forget about. And this obviously comes with its toll on the healthcare system. And it's not me advocating this, but if you look at the research papers, we know that healthcare system during conflict and post-conflict really get disadvantaged, and the mortality rate does go up in these circumstances. And this is obviously related to many things, particularly in Palestine. I mean, probably we're not like many places in Africa in terms of resources. So we are kind of resourced, but these are kind of certain difficulties which we have, and particularly where I think the college and certainly the policy unit will be an asset where we could develop things towards like development of human resources and some more sustainable systems. So with IMIT 2000, really, we started in Palestine officially back in 2008. And that was just as I was starting my job as a house officer here in Southampton. I joined my colleagues, and first thing we did, we looked at the priorities of the country. And no surprise, in a conflict zone, the conflicts were something to do around trauma and life-saving procedures, something revolving around ATLS, critical care training, basic life support, advanced cardiac life support, and all this stuff. But also a lot of this to do with anesthesia, which goes hand in hand with surgical training. And the other thing we kind of looked into, which was emphasized by Professor Habibi, is the need for really clinical audits and research to start looking at the working systems and identify the needs and where we can respond. But at the end of the day, we are a charity, and we are, I mean, a small to medium-sized charity based here in the United Kingdom, and we do fundraise through our annual fundraising event, and to kind of support missions of British colleagues to go there and help train in these areas. And this has obviously been very helpful and welcomed by the government, and certainly by the Minister of Health, but it did come with its own challenges, and we've learned a few of those, which has been emphasized all through the opening speech. But I thought I'll share with you some of those. Is again, I mean, it's the value of relationships, something we've learned all along. I mean, there are my colleagues, like some neurosurgeons, they do go to Gaza, for example, and they operate, and they do make big difference to the lives of the people who end on the table. But I mean, what I think we've learned from these is that it has to be a mutual trust. And this really should come, again, I'm going to repeat a few of those points. It's worth emphasizing those points. It needs to be based on the need. It's not like, I mean, we've got a group of people visiting, okay, let's see what they can do. We've got to ask the local people there, what do you need? And these should be tailored to the needs of the people. And this is something really we have done all along in IMIT 2000. And these things, there's a learning curve and they do take time. But I mean, yeah, we've started and it is happening. The other point to talk about here is this mutual learning. Quite often, and I have in the last 4 months realized this, like when I went to some of the universities in the United Kingdom asking whether they would be interested in a partnership, quite often, like we might look, I mean, say, look, I am in a university, I'm not going to name a university. Oh, what's my interest in a partnership with the Arab American University? It's not even in the top 300 universities in the world. We are in the top 10. Well, it doesn't work like that. I mean, me as a fellow of the college and as a trainee, as somebody who trained up in this country, I think we have that obligation towards the people in conflict zones and all other like low to middle income countries to do something. And there's a lot of good in it. Believe me, I've done this in the last 10, 15 years here. And I've sent students from the UK to go there to Jerusalem and have their elective courses there. And I invited people to come there. Every year we've been getting 5 to 10 students to come here. There's a lot in it for us as well, for our trainees, for our students. It's different pathologies. Like, I mean, in neurosurgery, how often do we get to see penetrating injuries? That's something there. Unfortunately, this is the bread and butter of neurosurgery. It's every week there's like at least 1 or 2 cases coming with that type of pathology. But there's a lot of things which can be of a mutual benefit. Advocacy is being emphasized again all along in this evening. Something I think we've learned it is very important. We have always looked for champions, both sides who are interested to kind of develop this mutual partnership or interest in training. But it's very important, and I could see this like as part of the policy unit, global surgery policy unit. This is something where I saw it like, I mean, top on the agenda, and it is right there, and it's something we've recognized here as a challenge, and we are aware of it, and it's worth developing. We've talked about local training needs. We've done surveys, and again, this is where research and data collection is very important, and I could see this again part of the strategy of the policy unit. And again, like, I mean, we've talked about this very last point. So probably I'm going to add like a couple of points here. It's again, not because I am an academic neurosurgeon, but I think research is something very important, and we can't make assumptions. Only in the 5 months I practiced in neurosurgery there, I've come to discover a lot of differences in disease, in presentation, the way, the approach, the cultural sensitivities, all of these things. I mean, quite often I say, well, this is what I did in the UK, probably it doesn't work here. I've got to think of things of doing it. I mean, I speak to my colleagues back in neurosurgery. I mean, the last few shunts I've done there, I mean, we're amazing shunts. It's proper plumbing job. It's I mean, with the difficulties, with what tubing you get there, you need to come up with all sorts of kind of novel ideas, which we quite often say, well, I mean, I remember me here in Cardiff saying, oh, everything is there on the tray, off you go. It doesn't work like that there. Multidisciplinary approaches, really, for me, I'm taking up the dean position on Wednesday in the School of Medicine in the Arab American University. And my thoughts here, and I hope, I mean, this is open for discussion, I think later on after we finish, is we need to start right from the beginning. This applies for surgery as much as it applies for other disciplines. We've got to implement certain ideas if we were to make a difference, not to wait until like they have learned all quote, quote, bad habits and think we're going to make change. I think we've got to start investing in undergraduate training and then take it into the next stage when it comes to surgical or anesthesia training. And again, we've got to improve this professional interaction between surgeons and anesthetists, between doctors and nurses. And if we were to make a difference, I think we've got to kind of look at this breadth of development. Like, I mean, I am a neurosurgeon there now, and believe it or not, I have to do everything. I am the nurse, I am the resident or the registrar, and I am the surgeon. And even I am the secretary quite often in my clinic. So this is where you, at the moment I've started, but it's just, unless like you could be the best surgeon in the world and you could do the best operation, then you go home. If you don't have a good nurse to look after your patient overnight, your outcomes will not be as good as you would hope. So this is where I think our approach probably will have to be kind of interdisciplinary and to be really to have a holistic approach to surgery, to all those involved in surgery, if we were to make difference. I mean, a lot of these solutions have been kind of outlined in the opening talk, but really it's all, I think, curriculum and protocols. I mean, we have well-established protocols here in surgery, something that really can be transferred easily, but again, can be tailored to the situation. It's something I think people locally will value, and me talking to the people there, I think they are interested in this. Again, there are ongoing programs, so we could, whether these undergraduate or postgraduate, we could step in and help with those. At Winnings, I mean, like this Prof can be between departments, can be between universities, hospital to hospital. It does not necessarily need to be a big thing. Even we could start with small things, build into that, and kind of develop it. So I'm going to leave you with this, vision. I think when we talk about partnerships, it is a revolving door strategy. It's never going to be one way. And I do believe that we in the North, if you like, we will benefit from this. So if I was to talk about this in the simplest, in a very simplistic way, on one side, and I can speak on behalf of this because you could count me as an advocate, Rachel, for this. And then we've got the American University, reasonably resourced, okay, with its affiliated teaching hospitals, both on the governmental side and on the private side, and from different geographical areas, whether that's in Ramallah or in the less privileged area of Jenin. On the other side, we've got multiple universities. So last week we signed up an MOU with Dundee University, and we are going to work on multiple items, and it's very promising. And what I love in it, we started working immediately on the different aspects of it while the delegation was still there in Palestine. But I mean, we could probably move the GSPU to in the middle to mediate. But I think I'm working with the Dean of the School of Medicine in Cardiff, where I worked for the last 10 years to develop a partnership in research. Certainly, I'm working with colleagues from Oxford. Today I had lunch with Tim Goodacre and Nick Maynard. So we are developing this partnership. They were a few months ago in Gaza on a mission, and they're doing good, really great job when it comes to training, teaching, but also to patient care. And where I think the policy unit alongside IME 2000 would fit probably in mediating and bridging the gap and bringing people together. And I think with that we could deliver a model which we could model it in Palestine, but then roll it over to other places if deemed successful. I'll leave you with that note, and thank you for the invitation again.
Thank you. Now I'm hoping the technology's working, and I'd like to welcome Professor Sherry Wren. Yes,
thank you very much. I hope you can hear me.
Excellent. Yes, perfect.
Whoever running the Zoom needs to allow me to share my screen. I'm disabled right now from sharing.
Can we facilitate that? Yeah. Should be coming through for you now.
It is. Thank you. I'm ready now.
Great. Okay, so Professor Wren is well known to many of you here. She's an expert in humanitarian and global surgery in Stanford, where she's vice chair of the Department of Surgery and also director of the global surgery in the Center for Innovation and Global Health at Stanford University. We're delighted that she's able to be with us tonight, and she's going to talk about gender inequality in global surgery, finding the forgotten women. Thank you. I'll hand over to you now.
Thank you very much. I so wish I could be there. A faulty brake unit on the airplane is responsible. I first want to call out attention to Prof. Abebe's talk, expert talk. I really think that talk should be sort of a prerequisite for anybody thinking about discussing global surgery. And I give him a lot of credit for putting disease names to all of these entities. And I'm going to talk about a somewhat provocative topic, which is finding the forgotten woman. And okay, let me see if I can get this to share. There we go. I think we're all talking about surgical workforce and all the needs. The global population is increasing. We're seeing increased life expectancy, the aging of the current surgical workforce. There's preferential distribution of specialists to urban areas, and then out-migration of trained specialists to other countries. and has been raised before, we see an increase in different diseases, especially in the non-communicable diseases. This graph really represents from 1990 to 2019, the proportion of deaths around the world. And as you see, the yellow deaths, our injuries, are staying fairly stable in numbers. The blue deaths, which are from non-communicable diseases, are greatly increasing. And as people age more, this will even become larger. And because of interventions in public health, we've seen big advances in improving maternal health and health due to communicable diseases. This, though, will contribute to an increase in procedural demand. For non-communicable diseases, surgical procedures really assist in the diagnosis, treatment, and palliation of things such as cancer, diabetes, cardiovascular disease. Cancer alone has been projected to have an incidence increase of more than 92% by 2040 in sub-Saharan Africa. The Lancet Commission in 2015 estimated at that time just over 320 million inpatient surgical procedures were necessary. And if you look at the breakdown, even then the vast majority of these were for non-communicable diseases. I think everybody was aware that in 2015, the Millennial Development Goals set this 2030 goal that we were supposed to have a minimum workforce of surgeons, obstetrics, and anesthetists per 100,000 of 20 people. When they set the goal, the workforce was going to have to double to meet that by 2030. And frankly, this has been unachievable. There's a number of solutions you could look at: task shifting, increasing trainees, and what I want to talk about is increasing women's representation. When you look at this map, the worst deficits were really in sub-Saharan Africa and Southeast Asia. But is that really what it is? So what I'd like to do is expand this and really look around the world to see what's going on. This was just published fairly recently, and this looked at that SAO workforce in many different countries. And you can see in Sierra Leone at the lowest in this data was at 0.2 of that SAO workforce per 100,000, going up to Israel, which has about 69. So clearly there are many countries in this world that are still left with the minimum of 20 of the SAO workforce. So is this just a global South issue, or is it a world issue? Even here in the United States, we've had data for years projecting significant surgical workforce shortfalls in 9 out of 10 specialties in 2 years, let alone the increasing change as you move forward another 10 years. What's really interesting is when you look at the breakdown of surgeons by gender. General surgery, my specialty, actually has the highest percentage of female consultants, and orthopedics has the least. This is at a time that since 2009, at least half, or if not more than half, of the students entering into medicine are female. How about Britain, where you guys are all sitting in the UK? There's many news stories about these shortages of doctors, that you need almost 50,000 full-time doctors to reach this OECD standard. And we know that this includes surgeons. How about specialists in the UK? You have a pipeline of 64% of your students that are female. And for most of the surgical specialties, they're less than 20 or 15% represented. The consultants are women. I think one of the most interesting examples is Japan. It has the lowest percentage overall of female doctors. Less than about 5% of their workforce, surgical workforce, is female, but they are the oldest society because people live so long. So they are having this first full-fledged age society. And to many people's surprise, this was quite a scandal. In 2018, it became evident that for many years, multiple schools of medicine within Japan were purposely changing admission scores on tests for women applicants to actively keep them out of medical school. What happens once you get in is, what's the practice environment on women? And this manuscript just published last year, it looked at a province in Canada, 40 million referrals. And the bottom line is that there is a real gender effect on surgical referrals. And in fact, the male referrals, males under-refer to female surgeons, females less so. So This is a lot of barriers that we have to think about. There's been active discouragement to enter surgery. There's a hidden curriculum. You have to deal with a lot of perceptions about family issues, your physical and mental strength. It's a boys' club. And then there's sort of active and passive discrimination. Sort of a modern thought is that to see it to be it, that when 30% of the consultants are female, the field appears not to be male dominated and more women will then enter it. We still have to counter gender and social stereotypes, expectations, conscious and unconscious bias. And I think that the need for surgeons is going to continue increased based on population increases, disease changes. Women must be recruited into these specialties to address both the existing and increasing needs. I believe status quo is not an option. Surgery needs to actively make changes. Societies, colleges, and groups like this collaborative can really lead the way, because I do believe that engagement of women into the surgical workforce is a solution to this deficit, and we need to take advantage of it. But let's look at the other side of the equation. How about our patients? Are there gender disparities in the utilizations of procedures? This is a very complicated question, and one I would hope that this new collaborative could get into. Disease prevalence influences volumes, gender influences procedures. Males always have more trauma, more inguinal hernia. Females, of course, are going to have reproductive issues, C-section, hysterectomies, breast cancers. So this makes this a very challenging area to look at. Here's some striking examples, though. If you look at acute coronary syndrome, so for the non-physicians in the audience, this is having a heart attack or symptoms consistent with a heart attack. This came out of Australia, almost 30,000 patients. And this is a highly protocolized treatment. When you come in with certain symptoms, you're supposed to do certain things like get an angiogram. And what they found for all presenting types of acute coronary syndromes, women were less likely to get treated as men. It was not confounded by age or the type of presentation. And the sad thing is that this has been reported multiple times in the past. And this phrase in their discussion is a little disturbing, that physicians should be wary of inherent gender bias in decisions to refer patients for angiography. My own group did some work, collaborative work in Cameroon. And this is a hospital system where you literally pay a fee to be seen by the surgeon. And if you're going to have an operation or hospitalization, you pay a fee up front. We did pre and post clinic interviews in adults, and we only included patients that required a procedure, where a procedure was actually recommended. What did we find? We found that 1 in every 5 patients who needed a procedure declined it. More than 25% of them had traveled incredible distances, more than 5 hours to see this doctor, and had paid for it. Not surprisingly, the number one reason was for declining care was the cost of the care. But when you then did an analysis, a very predominant issue is the patient gender, and female gender was a statistical standout as well as source of payment, i.e., can you crowdsource your payment in declining surgery? I'm proud to sort of show this. So this is just being put into a paper. Prof. Abebe and I are co-authors on this. We took COSEXA, which is the largest training program in sub-Saharan Africa, and we used their resident case logs to look at gender equity in programs for non-gendered procedures. We picked 2 types of procedures here, skin and soft tissue and abdominal. We purposely excluded gendered procedures such as inguinal hernia, breast disease, genitourinary or reproductive organs of either gender. We then looked at male to female procedure ratios and did some analyses looking at the sustainable development goals of 3 and 5, which is health, access, and gender equity. We looked at more than 50,000 total procedures, and 62% of these were performed in males, 32% in females. What you can see here is what are the odds of having a male gender to get a procedure by country. We use Namibia here as the comparison group because it has the highest degree of universal health coverage. In 13 nations across the region, all but one, which is Botswana, had a higher number of males receiving procedures than females. And in soft tissue surgery, 8 out of 13 nations, and in abdominal procedures, 11 out of 13 nations had statistically higher chance of having men get interventions than women. So in conclusion, I think that there are disparities in the utilization of procedures. It cannot be explained by disease incidence alone. The responsible factors are unclear. It's likely societal, cultural, and economic. And to really make a difference, we have to understand this to reach gender parity in health. And I think Prof. Vitalis said this best. Women are not dying of diseases we cannot treat. They're dying because societies have yet to decide that their lives are worth saving. I'd like to thank this organization and this collaboration for the opportunity to share this with you today.
Thank you. That's certainly given us food for thought. And our final speaker in this session is Dr. Leçon Conte from the LSE. She's Associate Professorial Research Fellow in the Department of Health Policy and the Academic Director for the African Health Observatory. She's going to speak to us about priorities in resource allocation. And I think this is a really important topic, without which we can't really make progress on many of the other things that we've talked about tonight. So Leçon, welcome. Thank you.
Good evening, everyone. I am very mindful that I'm the last speaker and I'm the one standing between you and a champagne reception. So I will talk slowly. So thank you. Thank you for giving me a platform to reflect on an involvement in surgery that started as a commissioner for the Lancet Global Surgery. So I was one of 2 economists asked to join that endeavour. And as Professor Bebe says, I did go in with quite a sense of, hang on, I work on infectious disease, I work on malaria. It's a little bit of a luxury surgery, isn't it? Are we there yet to have this conversation? And through the commission and the work undertaken by the commission, I was completely converted. In fact, I feel that it's integral to system strengthening. And that's really what's going to be the thread of my talk today. I took away from that involvement, and I have really since then been more on the outside looking in. So I'm mindful again that I'm the 4th speaker on a panel of 3, and the previous 3 of you are getting into taxis and risking your lives, and you're doing really frontline great work in both the training and the provision space. And I'm working with my pastel spreadsheets, desperately trying to make a difference on the economic front. So we're coming at this from slightly different perspectives. And also I'm a little bit of an outsider looking in, and I hope doesn't mean that my comments tonight are superficial, but rather that they are really just, I noticed many parallels. When I was looking at the literature, I was thinking, so what's unique to surgery here? Could I have been giving this lecture in a malaria conference? And I think there are some things that are quite unique to surgery. So the Lancet Commission was published, and it really did feel like a sense of the beginning of a new momentum. And that's not to belittle all the work that went on before, but it felt like there was now a coordinated and a deliberate attempt to bring together the individuals within the countries they'd worked in to stop really recognizing the frustrations at a personal level and think about more systemic issues and think about a more coordinated voice in a very noisy global health space. I also noticed that the surgeons and the anaesthetists, there's an interesting dynamic there. I remember the anaesthetist saying, don't forget us. And it just reminded me of a health economist and epidemiologist. So that was another sort of a lesson learned. But since then, I've looked at the literature, and I revisited in a greater depth in the coming days to give this talk on where we are in terms of particularly the economic space and the financing space in global surgery. And this has afforded me quite a privilege to see what has progressed and what really still, what lessons and what evidence bases are still really lacking. So I organized my reading and I organized my thoughts and this talk to look at what influences and prioritizes funding from two perspectives. So if we're thinking about this box in the middle, what are the discussions going on within surgical care and within the surgical care systems? And by that, I was interested to see among the surgical community, what is it that you're prioritizing and looking at in your research in the economics and financing space? And as often is the case, there's quite a bit on cost effectiveness. I think there's a growing understanding and appetite to understand how to do things a bit more efficiently, how to put in the right inputs, and maybe how to do these things to a greater quality, but maybe less resource use. Then it's a growing literature then sort of on the back of that around frugal innovation. So not only do you know how to do things right, but again, is there even more capacity to think about moving out more high costly resources in terms of individuals or in terms of products and thinking about getting lower cost ones. But that doesn't mean compromising policy quality, but really thinking around delivery, but at a more sort of frugal end of the spectrum. And here I think is exciting because this again is an opportunity for my area of interest and my bias is sub-Saharan Africa, but the frugal innovations that are coming out of some of these surgical projects, they're for the world, for the globe to recognize and build on. So there's some real learnings that come from this frugal innovation. So we know something's cost effective, but who's going to pay for it? And so this is where the financing comes in. And one of the unit's members is here, Marty Lord, and I encourage you to read his paper on what's the landscape. It's around what is the evidence base around financing surgery, and it was focused on Africa. What struck me was the concentrated evidence base. So I think a third of the financing papers came from Nigeria, and maybe over a half from just 3 countries. And so again, there you've already got some sort of baked-in bias about where you're drawing your conclusion on what works, if you've got this narrow geographical lens. And again, when we were talking about financing, a lot of the evidence was around pooling and risk sharing. So there was an energy there to look at how do we share the money around, but there was a lot less literature on generating the money. And so I think that sort of resource mobilization is something that this unit and their partners need to look more around. And also purchasing. So you raised the money, you've worked out how it can sort of organize itself, but what do you spend it on to maximize your productivity? And that's both in the public and the private sector. And again, lacking evidence, I would suggest, in that space. Sherry and others on the panel have spoken to this point about equity and inequity. So you can have the glorious intervention, but you must ensure it reaches those in the most need. And there are various issues that many of you in this room will know much better than me around why access is an issue. And these are cultural, these are political, and I'll just focus on the economic one at this stage. The evidence on out-of-pocket payments is, I would say, unanimously suggesting that the heavy lift on attaining surgical care is coming from households, it's coming from individuals. And this out-of-pocket payment is a huge barrier. And what I found reading the literature, and I think, again, another thing that's specific to surgery was, yes, accessing care for malaria, for HIV, for many, many health conditions is a cost. There's cost barriers. Transport comes up as a cost. So it comes up in malaria, and that a lot of that delivery is actually in primary healthcare. But in surgery, many of the provisions are at the district and at the national tertiary level. So transport and reaching care brings on another set of costs, both direct and in time, in terms of missing work. The perioperative costs, so the costs not only of if you can afford to get to care, if you can afford to receive care, but then after that care, if that care really doesn't go to plan or it takes more time to mobilize and recover, these aftercare costs, I think there's a lot of work and reflection to be done on that, because even if care is so-called free in your benefit package, it's never really free. There really is always some kind of indirect, or we'd say opportunity cost associated with that. So unpacking those costs across a whole temporal sort of continuum, from when you recognize that you may not feel well until you're skipping and dancing at the end, I feel that really does need some more work done, and not this laser focus necessarily on only getting the technical and most sort of cost efficient, cost effective intervention in the surgery. So if we think about that within the surgical care space, this is all going on and these questions are all being answered, but in such a broader, louder context. And I haven't got time to go into all of these health system issues here that I've put on the slide, but to recognize a lot of the literature talks about the epidemiological transition, so the non-communicable diseases, and see the role of surgery as being absolutely foundational to that being addressed successfully. So there's an opportunity there. So maybe align with some of the surgical efforts with some of these disease-specific ones. In terms of domestic mobilization, again, this idea of being a passive recipient of care, those days are long gone. Really, the national governments are the ones that are picking up the big costs of surgery. It may not be in absolute numbers that lots is being spent on surgery, but they are doing the unglamorous, recognized work sometimes in countries. And there's a lot of emphasis and attention on these global efforts that come in and come out. But please, I would implore the unit to think around that domestic mobilization front. And then the biggie really for me when I'm sort of reading this is around the universal health coverage narrative. It's the dominant narrative in global health. It's the thing that people are laser focused on in terms of 2030. And this is I would suggest the platform that the global surgery community are already and should continue to work out their position within this very crowded and noisy space. I won't go into details on this slide, but again, this slide really is another, if you like, rebranding of my previous one. And it's to speak to this idea that surgery is almost, it's an opportunity and a threat, how much it's embedded in health systems. Because just like maternal and child health, it's a tracer almost of how functional and joined up your system is. And this emphasis on national or surgical obstetric and anaesthesia plans, these NSOPs, it's interesting to hear in the room how much these have or haven't gained traction in countries. And I wonder how much these are aligned to the benefit package and the bigger discussions around benefit package overall for UHC. Are they competing? Are they complementing? And I think there's work to be done there in terms of resource allocation, because I would suggest that if they're embedded in benefit packages, that are already being thought through in UHC space, then there's a real opportunity here for sort of the surgical thinking that's been happening already to be a catalyst for change across the wider system. So my final slide, the future financing strategies. And here I guess some of this may be a branding issue in the sense that surgery is different things to different people. So if we talk about malaria, my go-to, it's a little bit more clear about what you're dealing with there in terms of your interventions, in terms of your target audience. And so it's a little bit easier almost to get your head around, conceptualize and fund. Whereas surgery is multiple things. I mean, I think there's still debates what essential surgery is. But again, it's really hard then if you can't focus people's attention on a really crystal clear intervention, shall we say, or set of interventions. How do you then bring the funds and the finance and the commitment and the focus, political focus beyond that? But great work has been done. And I'd suggest that there's a real balancing act here to be done in terms of ensuring that the financing of surgery is embedded in the UHC agenda, in that benefit package, deciding what needs to be rolled out at a national level. But there's value in trying to maintain a distinct identity. And I think surgery have done that as well. Global surgery have, in the big beasts there, the malaria, the TBs, the HIV funding, but global surgery really has got increased momentum. I think it's important to have champions, and you spoke about champions in the community, and I totally agree, and champions within the health system and champions on the global stage as well, that recognize and join up this whole sort of route to change. And then surgery can also align to funding within specific diseases. So when you read the cancer literature, there's work being done about the importance of surgery and how it's central to that. So again, it's multiple identities. While they pose challenges, they also pose opportunities, because there's multiple entry points then for funding, for financing, for bringing on board your champions and showing how without fundamental good quality surgery, your health system's really never going to get to where you need it to be for UHC. So I will end by sort of challenging this unit, challenge them as an economist, challenging them as a part of the diaspora, to work in a context of equitable partnerships and recognizing their collaborators as intellectual equals, and learning what can be done on the ground, and from the community right to the global stage. It has to be joined up and talking to each other to build on what's been said before. Thank you.
Thank you very much. I'm aware of the time, and I think it's been worth the extra time for the very stimulating, challenging and interesting talks that we've all heard this evening. They've certainly raised a lot of questions in my mind and given me a lot of food for thought, and I hope that's true for all of you. In the interest of time, I wonder if our panelists would be happy to speak with people during the reception rather than take sort of formal questions on the stage, if that's okay. I'd like to thank all of them for their time, for the time they put into preparing and thinking about what to say tonight. It's been very thoughtful, very helpful, and, as I say, challenging. Thank you, all of you, for coming. A number of people sort of said to me as they came in, oh, we don't know much about what this unit is about, and so on. So I hope you know a bit more now than you did when you arrived. We are very much open to partnerships in the widest sense of the word. It's, for many of you have been involved in sort of research partnerships, and that's obviously a big area for us, but also partnerships around education, around philanthropy, around advocacy, and so on. You can see some of our early work in the sort of latter pages of the booklet that you've been given to when you came in, and some of the early research work is projected on the screens over there where we'll be having the drinks reception, but feel free to speak to any of us tonight. The research fellows and the unit staff are all here, or feel free to contact us. The details are in the back of the booklet. I'd like to thank you all for coming. I think Rocco wants to say a few closing words. No, he doesn't. He'll let me do the talking. That's the right way, Rocco. So thank you all very much.